Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. A virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 254 of our pharmacotherapy series, which majors in osteomyelitis and septic arthritis. The first question reads, JFA, a 52-year-old man, sustained a fracture of the right humerus in a farming accident 6 years ago. That fracture clinically healed without any immediate consequences. However, 1 year ago, a draining sinus tract developed at the site of the previous fracture without any antecedent events. He has taken various oral antibiotics during this last year, including amoxicillin and levofloxacin, which he stopped taking 2 months ago. 2 weeks ago he noted increased sinus drainage, pain, swelling, and erythema of his left upper arm, and levofloxacin was restarted. A swab culture of the sinus drainage grew Staphylococcus epidermidis, Escherichia coli, Peptostreptococcus micros, and Bacteroides species. Surgical debridement of bone and tissue was performed because of increased drainage and poor appearance of the wound. Gentamicin impregnated polymethylmethacrylate, abbreviated as PMMA, beads were placed in the tissue adjacent to the debrided bone during surgery. Bone cultures grew Proteus mirabilis and Bacteroides fragilis. The Proteus was resistant to ampicillin, cefazolin, levofloxacin, and tigecycline, but sensitive to sfotaxime, ceftriaxone, imipenem, gentamicin, and trimethoprim sulfamethoxazole. Antibiotic susceptibilities for the Bacteroides were not tested. So my question to you is, what aspects of JFA's case are characteristic of chronic osteomyelitis? Inadequate treatment of an acute episode of osteomyelitis can lead to formation of necrotic, infected bone and recurrent symptoms consistent with chronic disease. Despite appropriate initial therapy, osteomyelitis can reactivate, even with organisms different from the initial episode. Some propose that previously infected bone might be a risk for reinfection. Persistent symptoms or signs lasting longer than 10 days are consistent with chronic osteomyelitis and the development of necrotic bone. Draining sinus tracts often develop from the bone to the skin with chronic osteomyelitis. JFA probably experienced a chronic bone infection after the farming accident. The reappearance of sinus tract drainage in his left upper arm indicates an indolent infection of bone that was periodically suppressed, but not completely treated by oral antibiotics. Cultures of sinus drainage now reveal multiple organisms including normal skin flora. These sinus tract cultures usually do not correlate with the organisms actually causing bone infection. JFA's recurrent course of bone involvement with drainage and local symptoms, and lack of any remarkable systemic symptoms, suggests chronic osteomyelitis. The next question reads, oral levofloxacin, dosed at 500 mg daily, was restarted 2 weeks ago when JFA's left arm became more painful and drainage increased. Was his poor response to therapy unexpected? How should his case have been managed? JFA's poor response should have been expected for at least two reasons. Antibiotic therapy was started before surgical debridement of avascular tissue, and he was given an antibiotic that was inactive against the cultured bone organisms. Surgery plays an important role in the treatment of chronic osteomyelitis. Bone necrosis will continue to progress if decompression and drainage of the infected area is not carried out as soon as possible. Furthermore, without initial surgical removal of necrotic bone, sequestrum, and other poorly vascularized, infected material, even the most optimal IV antibiotics are likely to fail. After surgery, antibiotic therapy directed against the pathogens isolated in the surgical specimens should be started. The regimen choice should not be based on the sinus tract culture results because these isolates may not correlate with the actual causative organisms. JFA should be treated initially with IV antibiotics because of relatively poor blood flow at the infection site. Although the optimal duration of therapy for chronic osteomyelitis is not well established, the standard recommendation has been parenteral therapy for 6 weeks, followed by oral antibiotic therapy, depending on the healing rate. However, based on more recent data with oral antibiotics in chronic osteomyelitis, the susceptibility of the antibiotic for the organism is more relevant than the route of administration. JFA should continue to be evaluated by an orthopedic surgeon because he may require further surgical treatment to eradicate chronically infected bone. The next question reads, what would be reasonable antibiotic therapy for JFA? On the basis of the bone culture and sensitivity results, JFA needs high-dose therapy directed at Proteus mirabilis and Bacteroides fragilis. For convenience and possible future home therapy, ceftriaxone 2 grams IV every 24 hours could be started for coverage of Proteus, and metronidazole 500 mg IV every 8 hours also should be started for coverage of Bacteroides fragilis. Because of excellent oral bioavailability, the metronidazole can be rapidly converted to oral therapy at the same dose before discharge. Ertapenem could be an alternative choice for home IV therapy assuming that the Proteus isolate is sensitive. This agent also provides excellent anaerobic activity, and its once-daily dosing, that is 1 gram IV every 24 hours, is convenient for home therapy. After 6 to 8 weeks of home parenteral therapy, JFA should be evaluated for response. If symptoms have abated, treatment with oral antibiotics such as trimethoprim sulfamethoxazole and metronidazole may commence and should continue for an additional 6 to 8 weeks or longer depending on resolution of the sinus tract drainage, pain, and tenderness in JFA's arm. Under these circumstances, he should be monitored closely for possible long-term adverse drug effects, e.g., hepatitis, cytopenias, or neuropathy. If the sinus tract does not heal or if JFA remains symptomatic, surgical exploration and bone cultures must be repeated. The next question reads, what is the rationale for and effectiveness of local antibiotic administration, the PMMA beads, inserted during JFA's orthopedic surgery? To deliver high concentrations of antibiotics to poorly vascularized bone infection sites, various materials containing antibiotics can be placed at the infection site during surgery. Plaster pellets, fibrin, collagen, hydroxyapatite, and PMMA impregnated with antibiotic, usually an aminoglycoside or vancomycin, have been used. The dosage form is designed for the slow release of antibiotics from the material. The most commonly reported experience with local antibiotic delivery has been with antibiotic-impregnated PMMA cement or beads inserted during joint arthroplasty. Local delivery of antibiotics should not replace systemic antibiotics in the treatment of chronic osteomyelitis. The next question reads, FAT, a 47-year-old woman, had a left knee replacement 1 year ago for osteoarthritis. She is seen today in the orthopedic clinic because of increasing left knee pain for the past 2 months. The knee is painful and warm. She is afebrile, and her peripheral WBC count is 9,800 per microliter. Aspiration of fluid from the knee reveals a total nucleated cell count of 78,000 per microliter with 90% neutrophils. A gram stain of this fluid shows 4+ polymorphonuclear leukocytes (PMNs) and 1+ gram-positive cocci. She is started on antibiotic therapy with vancomycin and ciprofloxacin pending culture results, and she is scheduled for operative evaluation and possible removal of her prosthetic joint. So my question to you is, does FAT have a prosthetic joint infection? Joint replacement surgery is commonly performed for patients with significant joint destruction as a result of arthritis and other disabling diseases. Prosthetic knee, shoulder, elbow or hip devices made of metallic alloys are cemented to adjacent bone to re-establish joint function. Infection of these foreign bodies can occur because of exogenous inoculation of bacteria perioperatively, via hematogenous dissemination of bacteria, or by contiguous spread from a topical wound. Bacteria infect bone adjacent to the joint prosthesis, including the bone cement interface, resulting in a loosened and less functional prosthesis. Staphylococcus species including coagulase-negative species such as Staphylococcus epidermidis are most commonly involved in prosthetic joint infections, followed by Streptococcus species, gram-negative bacilli, and anaerobes. Although coagulase-negative staphylococci are usually considered a contaminant in culture, this organism readily adheres to prosthetic material and should be considered pathogenic when cultured from prostheses. Coagulase-negative staphylococci are often methicillin-resistant but susceptible to vancomycin. Chronic pain, swelling, erythema, and tenderness over a prosthetic joint are typical findings associated with prosthetic joint infection. Persistent wound drainage may also be present. FAT has had a relatively lengthy duration of symptoms associated with her left knee, which could be caused by joint loosening, but the cell count and differential from the joint aspirate suggest joint infection. Consistent with infected prosthesis is also the predominance of neutrophils in her joint fluid and gram-positive cocci on a gram stain. As is often the case, she has no obvious preceding source of infection from which bacteria may have originated. Occasionally, sources of infection with hematogenous dissemination to the prosthetic joint are identified, such as dental infections, cellulitis, or urinary tract infections. Given the gram stain result, FAT should receive coverage for Staphylococcus and Streptococcus species with vancomycin while awaiting the results of cultures and sensitivities. Because gram-negative bacteria also can infect these joints, gram-negative coverage is reasonable until the results of joint fluid cultures are available. The next question reads, does FAT need surgery and antibiotics to cure her infection? Surgical removal of FAT's knee prosthesis in conjunction with intravenous antibiotics for 6 weeks is the current recommendation for optimal eradication of prosthetic joint infection. A 2-stage orthopedic procedure is frequently used that involves removal of the infected prosthesis, placement of an antibiotic-filled spacer, joint immobilization, and antibiotics for 6 weeks. If the joint space remains culture negative after 2 weeks of antibiotics, a new joint prosthesis is then reinserted. Because a vascular bone cement and prosthetic material can become seeded with bacteria, complete removal of this material is necessary to have the greatest chance of curing the infection. 6 weeks of systemic antibiotic therapy in combination with orthopedic surgery results in restoration of joint function in 80% to 90% of cases. High rates of treatment failure occur if the joint prosthesis is not removed, if the antibiotic duration is too short, and if chronic suppressive antibiotics are not given. The next question reads, the surgeon is unable to completely remove FAT's prosthetic joint. The removed lining material and 3 swabs of the left knee prosthesis grow MRSA. What antibiotic regimen could be used? How long should FAT be treated? Because FAT's prosthesis cannot be removed, she will need 2 to 6 weeks of vancomycin, dosed at 15 mg per kilogram IV every 12 hours, plus oral rifampin, dosed at 300 to 450 mg orally twice daily, followed by 6 months of oral antibiotics plus rifampin. Daptomycin, dosed at 6 to 10 mg per kilogram IV daily, or linezolid, dosed at 600 mg orally or IV every 12 hours may be considered alternatives to vancomycin, depending on pathogen susceptibility, drug allergies or intolerances, and potential drug-drug interactions. However, these agents are not FDA approved for prosthetic joint infections, and they require monitoring for adverse effects, such as creatine kinase elevations in the CSE of daptomycin use, and bone marrow suppression and neuropathy in the CSE of linezolid use. Combination therapy with rifampin should be used for prosthetic joint infection caused by staphylococci, particularly if removal of the infected prosthesis is not possible, because rifampin penetrates bacterial membranes and biofilms to enhance the bactericidal activity of the antibiotic regimen. Monotherapy with rifampin should never be used because of rapid development of resistance. Rifampin induces the metabolism of multiple other agents, e.g., warfarin, anticonvulsants, azole antifungals, therefore, a thorough review of FAT's medication profile is critical. FAT's baseline liver function should also be evaluated and rechecked at least monthly while she is taking rifampin. Additionally, weekly assessment of FAT's complete blood count and renal function along with periodic vancomycin trough serum concentrations should be performed. The next question reads, ACH, a 45-year-old man, is referred to the rheumatology clinic for left knee swelling. 2 days ago, his left knee became painful and swollen, and he is unable to flex the joint. He also recorded temperatures at home of 100.7 degrees Fahrenheit to 102 degrees Fahrenheit for at least 4 days. In clinic, a joint effusion is noted, and fluid is aspirated for cell count, gram stain, and culture. His medical history is unremarkable. ACH's WBC count is 16,000 per microliter, and his ESR is 42 mm per hour. The synovial fluid from his right knee contains 30,000 WBC per microliter with 90% neutrophils, and the gram stain shows gram-positive cocci in clusters. Culture results are pending. His temperature is 38.5 degrees Celsius. So my question to you is, what findings in ACH are consistent with septic arthritis? ACH has an acute onset of monoarticular joint pain and swelling, with reduced range of motion and fever. These findings are classic for septic, non-gonococcal arthritis. The joint effusion shows a predominance of neutrophils, which confirms the diagnosis. ACH's knee has been infected hematogenously from a distant, unrecognized, source of infection. The knee is infected most frequently, and the most common causative pathogens are gram-positive, including Staphylococcus, Streptococcus, and Enterococcus species. A single joint is infected in 80% to 90% of non-gonococcal arthritis cases. Other possible sites of infectious arthritis in adults besides the knee include the hip, shoulder, sternoclavicular, sacroiliac, and ankle joints. Patients commonly present with fever, pain, swelling, redness, and decreased mobility of the involved joint. As illustrated by ACH, most patients have joint effusion on physical examination. When evaluating a patient with possible septic arthritis, any purulent joint effusion should be considered septic until proven otherwise. Alternatively, non-infectious conditions may be present, such as single joint involvement with synovial effusions in acute rheumatoid arthritis, gout, or chondrocalcinosis. Aspirated joint fluid should be cultured because isolation of bacteria is the only definitive diagnostic test for bacterial arthritis. ACH's joint fluid picture is typical. The leukocyte count in the synovial fluid usually is elevated significantly, with counts above 50,000 per microliter with a predominance of neutrophils, that is above 75%. Blood cultures are positive in 25% to 70% of patients. Another laboratory finding in ACH consistent with infectious arthritis is the elevated ESR and peripheral WBC count. CRP is frequently elevated as well, although both ESR and CRP are nonspecific markers of inflammation and can be elevated due to causes other than infectious arthritis. The patient's age impacts the most common bacterial cause of infection. In adults older than 30 years of age such as ACH, and in children older than 2 years of age, Staphylococcus aureus is the most common bacterial source. In sexually active young adults, Neisseria gonorrhoeae is more likely to be the causative agent. Streptococci, such as group A, beta hemolytic streptococci, can cause infection in children and adults. Other organisms, such as group B streptococci, anaerobic streptococci, and gram-negative bacteria, can also cause infection. Gram-negative bacilli are responsible for approximately 5% to 20% of cases and often infect multiple joints. Infections with gram-negative bacteria usually are associated with predisposing factors, such as rheumatoid arthritis, osteoarthritis, history of joint surgery, intra-articular injections, or intravenous drug use. An organism commonly isolated from patients with bacterial arthritis who have a history of IV drug use is Pseudomonas aeruginosa. The next question reads, how should ACH be treated, and for how long? How should the efficacy of treatment be monitored? Treatment of non-gonococcal arthritis includes drainage of purulent joint fluid by needle aspiration or surgery, and appropriate antibiotic therapy. Because of the increasing frequency of community-acquired MRSA-causing infection, initial empiric therapy with vancomycin, dosed at 15 mg per kilogram per dose IV every 12 hours, goal serum trough concentration 15 to 20 mg per liter, should be initiated to provide coverage for this and streptococci in ACH. Daptomycin and linezolid are typically reserved for patients with vancomycin intermediate susceptible or resistant gram-positive organisms or those patients with intolerance or allergy to vancomycin. Vancomycin can be changed on the basis of sensitivity testing to oxacillin, nafcillin, or cefazolin if the isolated organism is susceptible. Regarding the duration of therapy, no high-quality studies have been performed to determine the optimal duration of therapy for bacterial arthritis. Previous recommendations based on early clinical trials recommended treating for 2 to 3 weeks. However, current recommendations are to initiate therapy with at least 2 weeks of IV antibiotics, followed by oral antibiotics, if possible based on susceptibilities, for at least 4 more weeks. ACH should be treated for at least 4 weeks. His response to therapy should be monitored clinically, resolution of symptoms, fever, and falling ESR, CRP, or both, as well as by periodic evaluation of joint fluid. frequent aspirations of joint fluid via closed needle aspiration or following arthroscopic lavage, and debridement and insertion of drains will permit daily evaluation of cell count and fluid culture. Effective therapy should result in a decreasing WBC count in the joint fluid and negative cultures, usually within 3 to 4 days of treatment. Joint inflammation and other symptoms also should diminish during the first week of treatment. The duration of articular symptoms before antibiotic therapy begun correlates with the subsequent time required to sterilize the synovial fluid. Therefore, delay in initiating antibiotic treatment may necessitate a longer course of therapy. Similar to hematogenous osteomyelitis, oral antibiotics have been used in septic arthritis to complete treatment if the initial response to IV therapy is adequate for some pathogens and in patients at lower risk for recurrent infection. ACH should be advised that parenteral treatment with vancomycin, which can be accomplished at home, would be the most effective mode of treatment if his cultures grow MRSA, because this pathogen typically requires 4 weeks of IV antibiotics. Finally, injections of antibiotics into the joint space are of no value. Most systemic antibiotics readily penetrate the joint space and enter the synovial fluid. Regarding gonococcal arthritis, polyarticular arthritis in a young, sexually active adult is caused most commonly by Neisseria gonorrhoeae. Arthritis in multiple joints is a common feature of disseminated gonococcal infection, abbreviated as DGI. Unlike non-gonococcal arthritis, which is almost exclusively monoarticular, gonococcal arthritis involves multiple joints in approximately 50% of cases. Women have a 4-fold increased risk of developing gonococcal arthritis as compared with men, often due to delays in diagnosis of genital infection. Clinically, patients present with a migratory polyarthralgia, often with fever, dermatitis, and tenosynovitis. Skin lesions are an important clue to the diagnosis of disseminated gonococcal infection and often begin as tiny erythematous papules and develop into larger vesicles. As in hematogenously acquired non-gonococcal arthritis, the synovial fluid leukocyte count usually is elevated, but often to a lesser degree. Neisseria gonorrhoeae is recovered in approximately 50% of purulent joint effusions, but is detected using polymerase chain reaction (PCR) assays that have approximately 96% specificity and 80% sensitivity. These laboratory studies, coupled with the patient's clinical presentation, can be used to make a definitive diagnosis. The next question reads, RED, a 21-year-old woman presents to the walk-in clinic with right knee and right shoulder pain, nausea, and vomiting. On physical examination, her right knee is swollen and she has decreased range of motion of her right shoulder. Several erythematous, papular skin lesions are noted on both hands. She also has a vaginal discharge. Her temperature is 38.2 degrees Celsius, and her WBC count is 15,000 per microliter. She gives a history of having 2 recent sexual partners. Cultures of blood, joint fluid, and vaginal discharge are obtained. A joint fluid gram stain shows 4+ PMNs, but no organisms are seen. So my question to you is, why is RED considered to have gonococcal arthritis? RED has systemic signs of infection, such as fever, nausea, vomiting, and leukocytosis, skin lesions, and multiple joint involvement, which are classic for disseminated gonococcal infection abbreviated as DGI. Her history of recent sexual activity and the presence of a vaginal discharge are consistent with gonococcal infection, although evidence of mucosal infection with Neisseria gonorrhoeae is not necessary for disseminated infection to occur. The next question reads, what additional workup should be done in RED? Can she be treated immediately in the clinic? RED should be evaluated for other sexually transmitted diseases, specifically syphilis and HIV infection. Serologic testing for syphilis, rapid plasma reagent abbreviated as RPR, or venereal disease research laboratory abbreviated as VDRL testing, and for antibody to HIV should be obtained. In addition, she should have a pregnancy test because some of the antibiotics that may be used are contraindicated during pregnancy, including doxycycline. Because of possible penicillinase production by Neisseria gonorrhoeae, recommended therapy is with ceftriaxone, dosed at 1 gram intramuscularly or IV every 24 hours, for at least 7 days. RED should receive her first dose of ceftriaxone in the clinic today. Conversion to oral antibiotics should be guided by antimicrobial susceptibility testing following 24 to 48 hours of clinical improvement by the patient. RED's sexual partners should also be evaluated and treated for relevant sexually transmitted diseases. She should also be counseled on utilization of barrier methods, e.g., condoms, to prevent sexually transmitted infections. The next question reads: results of RPR and pregnancy testing in RED are negative. So my question to you is, how should she complete her course of therapy? RED's disseminated gonococcal infection abbreviated as DGI should be treated for at least 7 days. RED also should begin treatment with azithromycin, dosed at 1 gram orally once, or doxycycline dosed at 100 mg orally twice daily for 7 days, for the possibility of concomitant chlamydial infection. Azithromycin is preferred because of increasing resistance with tetracyclines. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 255.